Gaucher disease is a metabolic disorder, is a systematic disease being classified to the so-called lysosomal storage disorders. And actually, in this group is considered the most common, although, of course, is a rare disease as the whole group of these diseases belong to the category of rare diseases.
Welcome to the EHA Unplugged, the official podcast of the European Hematology Association, EHA. I'm your host, Professor Sam Salek, and today's guest is Professor Argiris Symeonidis. Professor Symeonidis is the Professor of Hematology in the University of Patras, Greece, and he's also the President of the Greek MDS study group, and in addition to that is the country coordinator of Greece in the European MDS registry. He also is the founder and the coordinator of the Greek National MDS registry. In terms of his interest, he's a MDS specialist, bone marrow failure specialist, and plasma cell discresis, and most importantly, a specialist in Gaucher disease. Professor Symeonidis, welcome to this podcast.
Dear Sam, thanks for inviting me to this interesting discussion. And I think we are going to discuss on a very fascinating disease, which is actually a rare disease. However, there is a strong involvement of the hematologist and of the area of hematology in the management of this disease. So I think we should show with our discussion this contribution of our specialty of hematology in order to alert all hematologists that they should be aware of the presence of this disease.
Well, thank you for that, Argiris. I'm really looking forward to the conversation that we're going to have about the importance of the curriculum for the hematologists in the field of the Gaucher disease and the associated aspect that are related to that curriculum. So let's start with my first discussion point. Argiris, could you tell us what kind of disease is Gaucher disease?
Yes, well, Gaucher disease is a metabolic disorder, is a systematic disease being classified to the so-called lysosomal storage disorders. And actually, in this group is considered the most common, although, of course, is a rare disease as the whole group of these diseases belong to the category of rare diseases. Gaucher disease stems from a mutation occurring in the glucocerebrosidase gene, which results in the accumulation of an undigested metabolic compound, which has to be transported and accumulated in the organs of the reticuloendothelial system, thus resulting in the enlargement of the organs of the reticuloendothelial system. There are several consequences of this pathophysiology, and this result in the clinical manifestation of the disease. It is a systematic disease affecting many aspects, organs, and systems, and one of the main specialties involved is the specialty of hematology.
Is Gaucher disease a pediatric or an adulthood disease?
Yes, well, the answer to this question depends on the age of clinical manifestation of the disease. In the most severe forms of the disease, the clinical manifestations comes early, and so the main doctor dealing with disease might be the pediatrician. For 60% of the cases, the first manifestation of the disease come in adulthood, in second or third decade of life, and occasionally even later, so that the affected person, the affected patient, is quite unaware of the presence of this disease and may be referred to a specialist who is not aware about the presence of this disease.
So if we are considering a young hematologist who doesn't know very much about the Gaucher disease, what are really the main manifestation, perhaps if you could mention one or two, that would make the young hematologist suspicious of a Gaucher disease?
I would say that the main manifestation of this disease are practically the enlargement of the liver and spleen, and particularly the spleen, and the severity of this enlargement is directly related to the severity of the mutation producing the disease. That means that in the most severe cases, splenomegaly might be severe and symptomatic, whereas in the less severe cases, splenomegaly might be almost asymptomatic.
I would like now to focus on the epidemiology of the Gaucher disease. How common or rare is it?
Yeah. Well, it is really a rare disease. It has been estimated that we have one birth of an affected person on average every 40 to 50,000 births. This is incidence on the general population. However, there are some ethnic differences, several ethnic differences, and the disease is much more common among the Ashkenazi Jews, in which disease occurs with an incidence of one affected person every 850 births. That is a frequency of 50 times more common than what is occurred in the general population.
You mentioned something that obviously sparked another point for me, and that is, despite the fact that it's rare, which part of the world you find the majority of the prevalence?
Well, I would also like to mention the point prevalence. In the general population, the point prevalence is considered to be one affected person every 100,000 people, but this is the precisely diagnosed cases, and it is estimated that one additional case exists which is as yet undiscovered. So the real incidence might be twice as high as that I described previously.
You mentioned that it's more prevalent in Ashkenazi.
Yes, of course. So this is 50 times more common.
Right. So does that mean that they are more prevalent in places such as Israel, for example?
Yes, this is correct.
Now, in terms of the important aspect of the diagnosis of the Gaucher disease, which one of the consequences would be related to the delayed diagnosis? So in terms of, for example, when the hematologists get a chance to see the Gaucher disease, would that be at the start of the diagnosis or when they find their way to hematologists, pretty much in the later stage?
Disease is mainly manifested with enlargement of the organs of reticuloendothelial system and particularly the spleen. But if the disease will not be discovered at early stage, the consequence should be that the undigested component will accumulate in other organs, in the macrophages, and enrich in other organs, and particularly the bones. And as a result, this disease in late diagnosis might be associated with bone disease of different severity. And in some cases, this severity is high and may mimic neoplastic disorders associated with bone destruction. So, for example, this might really mimic metastatic bone disease or multiple myeloma, or in other cases, and bone cysts which might be considered initially as benign, but then they are enlarged and they are producing symptoms, including also abnormal fractures, bone fractures. In other cases, before the level of structures, of bone structures, the patient experience bone pain, which is sudden and, let's say, of a variable severity, and sometimes it comes with a frequency and with a high intensification, and this is called bone crisis. Such bone crisis may manifest in the later stages of the disease, and these, I would say, are the consequences of the late diagnosis. Other consequences of the late diagnosis might be the development of various unpredicted neurological manifestations, which are also unpredictable and may lead the patient to address a neurologist. Particularly, this is more common among the most severe cases and the so-called type 3 of the disease, and of course in type 2, and are less prominent in the most common type 1, the less severe type of.
You mentioned different types of Gaucher disease. Would you briefly just describe type 1, 2, and 3? And which one of those are more prone to present itself as a late diagnosis?
The most common type is the type 1 of the disease, and this is the less severe type, usually diagnosed in late childhood or in the adulthood. Maybe we have experience in diagnosing type 1 patients with Gaucher disease even at the age of 40 and 50-year-old. This type of disease is usually less symptomatic, and the doctor, the treating physician, should evaluate the patient carefully and understand and realize when has to start interfere with the progress of the disease. Besides the type 1, there are two other forms which are called neuronopathic forms of the disease. And the most severe is type 2, and type 2 is the result of severe mutation abrogating completely the function of glucocerebrosidase, and thus is associated with neurologic manifestation early in life. So these patients should start immediately treatment as soon as the disease has been diagnosed in the early months. Even when the appropriate treatment is administered, this has the most dismal prognosis, and the child may not be develop very well. They may show growth retardation, severe organ involvement, and finally they may succumb, not reaching even the 10th year of life. There is a third type, the so-called late neuronopathic type or type 3 disease, which is discovered in childhood but not in the first year of life. And this can be diagnosed and demand specific type of treatment, and when appropriately treated, these patients might have a better prognosis than those of type 2 disease.
So far, the conversation has brought me to two important points from my point of view. Do you think that the establishment of a curriculum for hematologists focusing on Gaucher disease would somehow help with the early diagnosis of Gaucher disease?
Yes.
So that's my first point. And my second point is that you mentioned the neurological impairment. Would you say that those who have Gaucher disease are more prone to developing things such as Parkinson's disease?
Yeah. First, I have to say why and in which circumstances the hematologist is involved in the diagnosis and potentially in the treatment of this disease. as I mentioned, the patients developed organomegaly, resulting in peripheral blood cytopenias, and among them the most common is thrombocytopenia. Therefore, when a patient is discovered having thrombocytopenia, is usually referred to the hematologist for the identification of the cause of thrombocytopenia. Either this might be autoimmune or might be neoplastic. And this is one of the main reasons of referring patients with Gaucher disease to a hematologist. Other reason is the discovery of the etiology of splenomegaly with a potential suspicion of a lymphoma or of a low-grade, usually lymphoma. And in rare circumstances, there are some uncommon, not easily classified hemorrhagic manifestation, so bruisiness and bleeding, and or maybe findings of unexpected hyperferritinemia. All these are reasons which may guide the referral of patients to a hematologist. On top of that, very common manifestation of a serum M component and with a potential diagnosis of monoclonal gammopathy of undetermined significance. This is also a very common cause of referring the patient to a hematologist. If the hematologist will approach the suspicion for the presence of this disease, one might go ahead and perform the appropriate diagnostic test to establish the diagnosis. Otherwise, the hematologist might go directly to perform bone marrow examination, which is not officially indicated for the establishment of diagnosis of this disease, and unexpectedly find that the bone marrow is, let's say, infiltrated, or there is an accumulation of abnormal monocytes, macrophages, which has the typical morphology of the so-called Gaucher cells, and thus establish the diagnosis of this disease. I again emphasize that performing bone marrow examination is not necessary and should not be performed, but whenever there is no suspicion of the disease, this is a way with which a doctor, a hematologist, reaches the diagnosis of this disease. Now, regarding the contribution of other specialties, of course, as a systematic disease, there are many specialties which contribute to the potential diagnosis and, of course, to the appropriate treatment of the disease. First of all, I would mention the endocrinologist, because one major symptom is growth retardation. I would also mention the orthopedics and the rheumatologist. Whenever the patient has manifestation of bone pain and bone disease or arthralgias. And in rare occasions, I would mention also the pulmonologist and the cardiologist when in some, let's say, more severe cases, the patient is referred to such specialties. On top of those, I would also mention the role of the neurologist, because as you have, many patients develop neurologic manifestation, and with particularly higher than expected incidence of sign of Parkinsonism, which is manifested early in life. So I would say that just because there is a pathophysiological interrelation and connection with the development of Parkinsonism, whenever this is suspected or diagnosed as not a late, let's say, a degenerative disease of the late adulthood, in all other circumstances, the neurologist should be aware for the potential presence of Gaucher disease.
That's very helpful. Thank you. Now, I want to, at this stage, focus on patient. Because after all, all the activities that is focused on diagnosing and treating Gaucher disease, who is at the receiving end? Now, you are the vice chair of the Gaucher disease task force for the European Hematology Association. I understand that when you had your meeting yesterday, a young hematologist from Italy approached you and expressed interest that she wants to specialize in particular in Gaucher disease. Now, with the fact that you have mentioned all these other specialities that feed into treatment and diagnosis of Gaucher disease, what would be your advice in terms of that young hematologist who wants to develop interest in Gaucher disease, in terms of how to communicate with other specialties that would make it easier and understandable, that the patients would be able to find its way through this maze of number of specialities?
The hematologist has a great and the primary, let's say, contribution in the diagnosis and potentially the treatment of this disease. As I mentioned, he or she may receive referrals to evaluate patients with common symptoms found in hematological disorder, but also because there are several consequences of the late disease associated with neoplastic hematological disorder, and there is an association of this disease with multiple myeloma, incidence of developing monoclonal gammopathy of undetermined significance. The hematologist should be capable and should be aware of the presence of this disease. So the hematologist should have the option to spend some small period of his training course in expert centers treating patients with this disease. And by so doing, I think that every hematologist has to gain many things, because after all, Gaucher disease is a very fascinating disease from the field, from the aspect of research. There are too many open as yet aspects for research which have not been completely identified regarding the pathophysiology of this disease. I would mention the strong immune component of this disease. I would also mention the association with neoplastic disorders, particularly of B lymphocyte origin. On top of multiple myeloma, there is a high incidence and high prevalence of B-cell malignancies, including various types of lymphoma. In some instances, Gaucher disease has been diagnosed on top of the initial diagnosis of a neoplastic malignancy. I practically had experience on such a patient who was diagnosed with Hodgkin lymphoma, and upon performing staging for this lymphoma, suddenly we encountered the presence of Gaucher cells in the marrow. So then Gaucher disease was established biochemically, and that was a discovery of a patient with neoplastic malignancy, which led, after all, to the diagnosis of Gaucher disease. So I think that the hematologist should be aware.
Well, we're fast approaching the end of our conversation, and there are 2 points that I must raise. First of all, I really want to see, in your opinion, what are the current effective treatment for Gaucher disease? And secondly, what is the prevalence of premature death in Gaucher disease?
Well, regarding the type of treatment, we have effective enzyme replacement therapy following the manufacturing of the normal enzyme, which is cerebrosidase and the glucocerebrosidase. And thus, patients have the opportunity to be treated, let's say, etiologically, because they are receiving replacement therapy as a correction of the malfunctioning enzyme. Beside this, there is another treatment option which directs towards the elimination of the formation of the abnormal substrate, and this is usually used in, let's say, less severe cases. By using these two different treatment modalities, patients have been happy that they can, at least the less severe cases, that the patients with type 1 disease may have almost quite normal, let's say, life expectancy, and only barely affecting their quality of life. But this, of course, is attributed to patients with type 1 disease. As I mentioned in the beginning, patients with type 2 disease, unfortunately, and despite the effective treatment of enzyme replacement therapy or substrate reduction therapy, they develop severe neurologic manifestation and neurologic degeneration, and that means that this treatment may not be enough to effectively reverse the consequence of the disease. Whereas patients with type 3 disease have shown a very good, let's say, response to combined modality therapy, and that has reached to a very important prolongation of their life expectancy.
Thank you very much indeed, Professor Symeonidis. As this has been a very enlightening conversation to have, and I would like to thank you for being with us. And I would like to thank the audience for listening, and stay tuned with us for more episodes of the Gaucher disease. This has been most educational.
Thank you also, Sam. Thank you for giving me the opportunity to have this discussion and creating to this podcast. And as soon as every hematologist will realize how nice is diagnosing and treating patients with this disease, he or she is going to be happy, learn more, and being more effective in the management of this disease. Thank you very much indeed.
Thank you very much indeed.